So thank you very much. I'm very excited to be here. These are cases, they're not all HCC. They are just various topics in liver disease and ones that I often do with the residents when I am on service. Honestly, I am probably going to be asking you more questions in my thirst to learn from how you guys do things. So please excuse me if these are too basic for your knowledge base. So the first case is a 69-year-old male with a history of hepatitis C with sustained virologic response 10 years ago, who presents with a new increase in liver chemistries, AST 45, ALT 60, and has had no follow-up with a hepatologist since he completed his hepatitis C therapy. He has a history of a BMI of 29, hypertension, and hyperlipidemia. So the question posed is, what are your concerns regarding this patient in terms of the increase in enzyme levels? So sure, the metabolic syndrome is a huge increase. The cardiometabolic risk factors that this patient has is the BMI, hypertension, hyperlipidemia. I didn't give you the race of or the ethnicity of this patient, but are you guys using PNPL3 much as a sending out as a diagnostic or kind of prognostic test? So I was doing that, but many of the insurance companies in the United States have said that they will not cover it because there's nothing that you can do once you find that results, and it costs approximately $4,000 in the United States to obtain that result. So unfortunately, we have not been able to get many of those patients in terms of what their PNPL3 status is. And what would be the next thing that you would consider doing next in this patient? Has had no care from a liver standpoint for the last 10 years. So HCV RNA, I didn't provide with you if this person is at risk of recurrent hepatitis C. That's one of the things that when I treat patients, I always go over with them that if they are ever exposed to hepatitis C, that they will be at risk of contracting this again. In the United States, the most common reason that we see acute hepatitis C is IV drug use and men who have sex with men. So risk for MASLD, we covered that. There are 3 cardiovascular risk factors: risk of recurrent hepatitis C, and then concerns for HCC. This is a patient who has had no care and therefore no HCC screening. And so we are screening everybody regardless of the duration that they have been free of hepatitis C. And how are you using prognostically the amount of scar tissue prior to initiation of hepatitis C? Are you doing biopsies, fiber scans? What is the predominant way to assess fibrosis? Fiber scan. So that's what we're mostly doing too. I remember back in the days when I was a resident, we would be doing liver biopsies every 5 years to see if patients had progressed to the point of stage 2 fibrosis. We use the Medivir in the United States. Are you guys using Medivir or Ishaq? Ishaq, okay, so that would have been a little bit higher stage. And once patients got to the, right in the middle is when we would consider using the toxic medications of interferon and ribavirin. Fortunately, we don't have to use those medications anymore, and therefore we're using fiber scans mostly. And what would you use the fiber scan pre or post SVR in terms of determining HCC screening, if it's warranted or not? So I'm totally with you. I thought it would be post because you get rid of all the inflammation, and we know that the fiber scan can be increased as a result of significant inflammation. If someone has a significant BMI, it tends to potentially overestimate it, heart failure, etc. But Nora Turow, who is one of the predominant hepatologists in the United States, who was very much a part of hepatitis C when it was a big issue in the United States, she made it very clear to everyone in the U.S. that we should be doing it prior to them getting their treatment. So, and that way we are probably overestimating the number of people that need to be screened. I've seen patients who had a liver biopsy prior to their hepatitis C treatment who had cirrhosis, and then I do a fiber scan years later, and it's a score of 4, so consistent with 0 to possibly 1. But the thought was to err on the side of over-screening patients as opposed to missing patients who clearly have cirrhosis after their therapy. So we're screening everybody. There are these calculators that are being used. However, I don't think they have been validated enough in order to say that we're going to screen some people and not screen others. We do have more calculators that I think are more mainstream, particularly in hepatitis B. In the U.S., we're using page B, and if they have a score less than 10 and no evidence of cirrhosis, no evidence of family history of underlying hepatitis or HCC, then we are saying that you don't need to screen those patients. However, I will say that I am still screening them, even though it is in our SSAD guidelines that screening is not needed. So this is our recall algorithm. Generally, what we do is, as you heard from Dr. Ahmed Singhal, is every 6 months doing an ultrasound with AFP. If a liver lesion is seen that is less than a centimeter, then generally we would screen them again in 3 to 6 months. Then we used to do that every 3 months for a total of 2 years, and then if there was no change, then go back to the 6 months. They have somewhat changed this and relaxed this, so we do this for about a year, and if there's no change, then we can go back to every 6 months. Some changes in our guidelines are the AFP level. If the AFP level is above 20, if there is an increase over 2 separate lab values, so 3 months and then 3 months later you see this increase, then we are going right to an MRI or a CT scan. Are you guys doing anything different in terms of the use of AFP and determining if an ultrasound or cross-sectional imaging should be used? Regardless of size, even if it's sub-centimeter? I would say that that's probably what we are doing mostly clinically, even though the guidelines are saying if it's sub-centimeter, then there is not the, you can continue to follow this. But there's a lot of angst and anxiety that patients get when you tell them, oh, you have a small liver lesion, and many of them would opt to get cross-sectional imaging. So I think this is the last part for that, yes. So this is actually a real case that I saw a couple years ago. This was a 35-year-old female with no significant past medical history, presenting with abdominal pain, nausea. Lab showed that AST was 4,000, ALT 5,000, bilirubin 1, creatinine 1.5, baseline is 0.5, INR 2.5 on no medications to cause an increase in the INR. On physical exam was oriented ×3, anecteric, and had some tenderness in the right upper quadrant. Medications that she was taking were OCPs, MVI, turmeric, and I did not include that she was also on a TNF inhibitor for inflammatory bowel disease. So this is kind of loaded with a bunch of potential differentials. So what would you be considering, or what would you want to do next? Pardon? Hepatitis A, we are seeing more hepatitis E in the United States. Generally, this is more of a cholestatic picture, but this was something that was sent on that patient. What else would you be considering other than a viral hepatitis? Drug, so DILI, drug-induced liver injury. The one thing that she is taking is turmeric. We are seeing that patients are taking turmeric in combination with black pepper, and there has been some data suggesting that black pepper can lead to a DILI. Anything else in the medications that you would worry about in terms of risk factors, given that there's some abdominal pain? OCP, so particularly, does this person have acute Budd-Chiari? There was no evidence that I gave you stating that there was evidence of ascites, but the abdominal pain is certainly a concern. In the United States, and also being female, one thing that we would be concerned about is the use of Tylenol. Given these liver enzyme levels, the bilirubin is normal, which is what we normally see in Tylenol, and then the increase in the INR is certainly a concern. So what lab for you is the most concerning for this patient? Exactly, so the INR, we see these enzyme levels, but if she had run a marathon, 2 days before, we have the Chicago Marathon, which is where I am from, and at Northwestern, we see tons of people who are admitted post-marathon, and their enzymes are very elevated. They may have some degree of increased renal dysfunction, and this is all due to that kind of hypoxic episodes from their running. But the INR is the most concerning, is signed. She doesn't have any evidence of encephalopathy at this point in time, but if that developed, she would meet criteria for acute liver failure. And I kind of just answered my own question. She does not have evidence of acute liver failure at this point in time. And what medication is concerning for possible etiology? So we talked about OCP, potentially was she taking any Tylenol, turmeric. I have not seen acute liver injury related to turmeric plus black pepper, but certainly would be a concern. She is also on a TNF inhibitor. So any other things that you would be concerned about knowing that there's some degree of immunosuppression? CMV, correct? Yeah, so I didn't give you any information in terms of history of new sexual partners, any evidence of further physical exam in terms of any rashes or new sores. Medications we talked about in terms of what would we specifically inquire about is Tylenol, and we would be doing a Tylenol level, but we now do not, even if the Tylenol level is negative, we don't wait for that. We would start NAC if there was any concern. There are the use of adjuncts that are being used it's not standard of care yet, but adjuncts you could get, and it tends to, if that is positive, then it goes along with this being Tylenol toxicity. And what vital sign would be the most important to you? And again, I'm thinking from what she had, so forgive me if this is not very obvious. Heart rate is important, but in terms of a non-viral, hepatitis B or hepatitis E or A. Yes, so, but you're going along the right line. So fever, if this is someone who has fever with these degree of increased enzymes, and I learned this from Andy Bly when I was a first year attending, if you see someone with enzymes this high plus fever, you want to make sure that this person does not have HSV hepatitis and start acyclovir until you can get those results back. Because if a patient has HSV, the time that it takes to start acyclovir is directly proportional to the chances of if they will survive that event. And what physical exam may help in this situation in terms of the liver? So size of the liver. If the liver, so people who generally have Tylenol toxicity or acute liver injury or acute liver failure, if she progressed, they tend to have a very collapsed liver. And when you look at their liver biopsy, when you look at the stains, you will see that that collapse has happened, and it often is misinterpreted as someone who has underlying cirrhosis, which is they would not meet acute liver failure if someone had cirrhosis. So if their liver is large, that gives you a clue for certain types of injuries such as Budd-Chiari, as well as HSV. It's not always been clear to me why HSV, if it's a degree of inflammation, but patients who have HSV-induced hepatitis tend to have a large liver. And we talked a little bit about acute liver failure here, and these are the more common and also things to consider. Again, this is through the lens of in the United States. In your expertise, what is the most common cause that you guys see for acute liver failure? Hepatitis A, okay. So in the U.S., we have somewhat new that, and we are held to a standard when we see our patients in clinic, particularly in the liver transplant clinic, if they're hepatitis A or hepatitis B vaccinated. And this is tracked. And if we are not making sure that everyone is vaccinated and then subsequently following through on vaccinating them, then it kind of is a red check mark against that portion of the transplant program. So hepatitis A and hepatitis B, we've become very unique or routinely that we are screening and vaccinating them. In the U.S. now, we used to not screen for hepatitis B because it is not as common. However, in the campaign to eliminate hepatitis B, we are now screening every single person just like we do in hepatitis C, and then suggesting that they be vaccinated if they are not immune, even if they do not have underlying chronic liver disease. And what criteria are you guys using for determination of acute liver failure? Is King's criteria still being used, or? I do too, so we use a different criteria. Okay. King's? Yeah, I find the King's criteria to be the most helpful and easiest to, maybe because it's the one that's been around a longer period of time, and so we've all memorized them. Also factor V, we will use that, looking at their age and their factor V level. Factor V generally takes us a day or two to get back, so it's not as helpful in terms of making that decision in a quick period of time. So drug-induced liver disease is common in the United States, particularly, as I mentioned, Tylenol is very common, and then different antibiotics are the more common, Augmentin, TB medications, etc. And then these are, high stakes. This is what I teach the residents, that if you see someone like this, what do you not want to miss in these patients, because time is of the essence. And speaking of time, okay, it's 9:16. I just wanted to make sure that I'm not going over. If someone could, I don't have a clock up here, give me a heads up. So HSV leading to acute liver failure, this is very rare in the United States, less than 1%, and more common in patients who are immunocompromised and pregnant. So most commonly when we see patients who have HSV, hepatitis leading to acute liver failure, this is in patients who have a brand new infection. However, there have been reports of patients who have had HSV in the past, and now they're on immunosuppression, so it's more of a reactivation. And then very rarely there are patients who have a toll-like receptor defect, where they can actually require a bone marrow transplant in order to be able to clear their HSV. So if you transplant them and they have this toll-like receptor defect, it will reoccur in the new liver. I have fortunately never seen that. I think that is pretty rare. So 80% to 90% mortality without early treatment. So it varies. I told you Dr. Bly was pounded this into us and all the residents that if you see fever and very high enzymes, to start acyclovir. It's a relatively benign medication until you receive the HSV PCR, which also can take several days. And one of the things that we are now using is something called BioFire. Are you guys familiar? Yeah, so this turnaround time of an hour that you can get this back. In the US, we used to have to get approval from the infectious disease physician in order to send it out because of the cost of the medication, but now that it's been around a little bit longer, we are able to more readily send this out. Up to 50% of the time, patients will have no evidence of having oral or genital lesions, so relying on the fact that if those lesions are present is wrong. Over 90% of the time, patients will have evidence of fever, and that's why fever is so important. And the diagnosis is often delayed, which leads to increase in mortality. In this specific woman, I had interviewed her in front of her mother and had been asking very personal questions. When her mother left, I re-asked those questions, and she had revealed that she had a new sexual partner about 2 weeks prior to her admission. So this was likely an acute HSV infection. She had no evidence of any oral sores. We did get her listed within 12 hours of her coming in. Unfortunately, she had to get set up for a line placement, and she had a femoral line place, which we generally don't do much because of risk of infection. And because of her coagulopathy, she had a massive hemorrhage and passed away and was unable to make it to transplantation. But a case that I will never forget, the only case of this that I have ever seen. Another do not miss is fulminant Wilson's. I've seen this in my career. I've had 3 people that have gone to transplantation who I was the attending when they came on. I often think of this as similar to syphilis. It's the great masquerader within liver disease itself, and it can be very difficult to diagnose because there is no one particular lab or even liver biopsy finding that will point you in the direction of securing the diagnosis of Wilson's. And have you guys seen acute Wilson's or Wilsonian crisis? Yeah, so it's pretty, once you start seeing it, their alkaline phosphatase, and a woman that I had seen, she came in, her alk phos was 130, and literally every single day it was declining to the point that by day 4 or 5, her alk phos was completely undetectable. And so she met this criteria of, the alk phos to bilirubin being less than 2. There was significant evidence of hemolysis. We used plasma exchange to get her through, and then subsequently was able to be transplanted. Case 3. This is a 59-year-old gentleman with a history of alcohol use disorder who presents with new onset jaundice and abdominal swelling. On labs, this is also a case that I saw not too long ago. AST was 650, ALT 400, bilirubin 7, INR 1.8, platelets 90,000. Triglycerides were very high, HDL was low, LDL 100, hemoglobin 7.9. During that admission, he underwent an EGD. There was no varices present, and he was seen by an addiction MD. We now are calling these addictionologists. These are popping up throughout the hospitals where patients are being seen in terms for their alcohol use. And he was also started on disulfiram as well as gemfibrozol. He was discharged, and I go to a satellite clinic at this hospital, and they wanted this person seen within 48 hours. And so this is what I was given. What would you do next with this information? What are your concerns? So that is not, I mean, certainly this gentleman he's telling you he has a history of alcohol, so there's no mystery there, but it doesn't make sense. These are not liver enzymes that we would expect to see in someone with alcohol alone. So we are thinking, is there something else? Any concerns in terms of the medications that were started? Yes. So disulfiram should not be used anymore. It is known to have liver toxicity, and I actually did contact the addictionologists. Addictionologists have the most information and learned in terms of the medications that we're using for alcohol use disorder. And this person's explanation was that they were so concerned that this person was not going to remain abstinent that they felt that they had to use this from their toolbox to help keep this person abstinent. And also gemfibrozol. In the United States, we had heard Sammy Saab, who was talking about PBC, that it is still in a box warning to not use in anybody with underlying liver disease, including PBC. So the fact that he was started on gemfibrozol as well as disulfiram simultaneously was my biggest concern as to what was going on. So I had stopped both of these medications when I had seen him in the office. Does he have cirrhosis? I think he did have cirrhosis. Which part of the liver panel is most helpful in assessing liver function? So HDL is actually another form of it can be used as a liver test. So when people have a very low HDL, it is very concerning. So his HDL was 20. Also could be seen in someone who has metabolic syndrome, particularly, males less than 40. That is a risk factor. And would you start steroids on this person? So we don't know if this is acute alcohol-induced hepatitis. We have a competing risk, drug-induced drug injury. There's no clear to say that you should use steroids in patients unless you are considering this is acute autoimmune hepatitis. The Lille score, which we use, I assume you guys are using this frequently too. We are using day 4 mostly, even though the studies had shown day 7. And I would say the reason
do we have iron studies in this patient? His hemoglobin is low. Do we have ferritin or iron or something?
I do not remember exactly what the iron was, but I would...
high triglyceride and low HDL.
No fever that was present.
Okay.
And HLH is something that we have seen a handful of times as well, and also very scary, high mortality rates. What ferritin, low hemoglobin, but if he did have alcohol-induced hepatitis, what would you expect the ferritin to be? High. In people who also, from the inflammatory state, also alcohol inhibits hepcidin, which is a regulatory agent that is part of our iron metabolism. So I've seen patients who are using alcohol who have ferritins that are over 1,000, and then when they have abstinence, it decreases. I just don't remember what his ferritin was off the top of my head, but a very, very good point. The reason we are using the discriminant function day 4 is because these patients are in the hospital, and they're generally under internal medicine. We have our own separate liver service, and it is limited to a cap of 12 patients because of our house staff, and there are very strict criteria in terms of how many patients can be followed by the house staff. So we don't have enough room on our service, so that the hospitalists want to get patients out of the hospital. They don't want to keep them there. So we're using day 4. We generally start steroids while they're in the hospital, wait till day 4, and then decide if we should discharge them on or off steroids. And this is the Lil score, and we had talked about this, that there's this time for changing, that the stigma that we see with using the term alcohol, that, and this is one of the things that I will, when I talk to a patient, I'm very clear that we no longer label the disease, we no longer label the person, but we label the disease, and that is a very disarming, in my opinion, in my experience, that patients will become a lot more truthful with you when you are telling them that you are not blaming them, that you are not putting this on them, that they have alcohol, that this is a disorder, this is a disease state. And this is something that we're really trying to push in terms of getting patients to be amenable to medications, to seeing someone. The first step is acknowledging that they do have an underlying issue. And then we talked about this as well. Are you guys using a PEth test? Yeah, so I have found that to be the greatest thing that has happened in terms of, and are you telling the patient when you're drawing it? Are you making them aware that you're sending it? So I pulled my hepatologist in this, and of the 11 of us, I was the only one who was telling them. The reason I tell is I want them to have a trust in me. We are in a patient-doctor relationship. So I will tell them, there is a test that we can do. This is going to show me if you have been drinking in the last 30 days. Nothing else makes it positive, although there was a study that showed that if you received a blood transfusion, that if the person you received the blood transfusion was drinking, that could potentially make it positive. But other than that, nothing else is supposed to make it positive. And I describe it to them as a hemoglobin A1C for alcohol. And I tell them if it's positive, you know, we're not going to argue about this, about cold medicines, or somebody put this in my drink or whatnot, that this is positive. And then I will send them a message if it's positive saying this is indicative of that you've been drinking moderate or heavy. And I think that also disarms them. And then I have patients who want it to be done, and it gives them a sense of control, I think. It gives them something that they can follow, and they're participating in their own care. I think I'll stop here to give Dr. Sham enough time. Any questions, comments, anything that you would like to share with me in terms of how you guys are doing things? I really appreciate all your insight. Thank you for the time, for being here, and the invitation. I've really enjoyed it.